Hi, I'm Dr. Ryan Ames. This is a wet lab that will go through several coding examples of clinical cases. So we'll present a case, go through the history of the exam and the medical decision making that was done, and then we'll grade it using the grading sheets that you've downloaded from the website. So this is the top of the grading sheet. You can see it's broken down into the case history and physical exam. The case history has the titles in orange there of HPI, the review of systems, and then past family social history. Underneath each one of those are the elements that you could just simply put a checkbox next to them when they are recorded in the exam. Once you do that, you can see if there's, on the HPI, for example, if you have 1 to 3 of the HPI elements documented, that would be brief. And if you have 4 or more, that's extended, and the review of systems and past family social history are laid out the same. Then, once you have extended a problem pertinent review of system and then a complete past family social history, you can look over onto the right there and circle those elements, and then it will tell you if it's a problem focus, expanded problem focus, detailed, or comprehensive history. Makes it pretty easy. You just check the box as you go through the record, and it tells you what level of history you've earned. Same with the physical exam. As you go through the exam, you just check off the graded elements there, and then you add them up. And you can see that on the bottom right there, it goes through how many each element is required to earn each one of those levels. The medical decision making does get a little more complex, but you can see on the top there, you just put in the number of diagnoses. So if there's 2 diagnoses that are pertinent to the case that day and 2 management options, so each diagnosis had a treatment plan, that would give you a total of 4, for example. Then you'd see in that box underneath there in the dark blue, it would show you 4 to 5 would be considered multiple. Then on the right are the level of risk, and the definitions for minimal, low, moderate, or high are right there. As we discussed in the last lecture, we rarely use the amount and complexity of data just because for eye care, for optometry, we don't typically have extensive amounts of data review or complex previous histories and things like that. So sometimes that's not graded very high. Plus, it's also a very subjective graded element. So because there's no definitive diagnosis of what those things are, we try to avoid that. So with the medical decision making, we typically are going to grade them on the number of diagnosis and management options and then the level of risk. That orange box there will then show you if you have for example, multiple diagnosis and management options and moderate risk, then that would give you moderate complexity for your MDM. So very easily lets you find what the medical decision making has earned. Then on the bottom, you see there's new patient criteria and established patient criteria for level 1 through level 5. And you just simply circle the history, the physical exam, and the MDM. And whatever those earned on the above part, then it will tell you what level of exam it earned. So we'll go through some examples, and I think once you've done this a few times, it becomes pretty quick and easy. On the back of that sheet, you'll see it breaks down the 92,000 codes. And the 92,000 codes are a little bit easier to grade. It's just a simple checkbox. Here you see for the intermediate ophthalmological service, you have the checkboxes on the top. If all of those are checked, it earned 92012 or 02. And for the comprehensive ophthalmological service, the same thing. If all those boxes are checked, it earns a comprehensive ophthalmological service. If even one is missing, it does not. You cannot use that code. So the strategic coding is a very interesting part of this sheet. What I've used here are the national average reimbursements for Medicare for this current year. So they might be off by a little bit by the time you've used it, but the ratios are pretty standard. The reason this is good to look at is that most visits earn either a 99 or a 92,000 code. So you can choose which one to use. And sometimes it's advantageous to use one code set over the other. What we typically will find is that if an office visit earns a 99213, so an established patient level 3, it very typically will also earn an intermediate established patient. So if you look at that, you can see that a 92012, an intermediate ophthalmological service on Medicare's national average reimbursement, is about $86. A established patient level 3, 99213, reimburses $73.93, so about $74. That's a $12 difference or so between these two visits. If you have the choice to bill a level 3 or an intermediate, which one makes the most sense to code? If the visit equally earns either code, why wouldn't you bill for the one that has the higher reimbursement? You maximize the reimbursements that way. $10 to $12 per visit may not sound like a lot, but of course extrapolate that over a couple times a day over the course of the week, month, and then the year. You're looking at thousands of dollars a year in net revenue. Simply by using a different code, by strategically billing the one that has the higher reimbursement, you can add huge amounts of money to your net revenue. Now, most payers are going to have different reimbursements than what you show here. In my area, I compared my top 5 or 6 payers, and the comparison between them stayed about the same. A level 3 always reimbursed less than an intermediate ophthalmological service for my visits. It wasn't always $13. For a couple, it was a little bit more. For some of the payers, it was only about $5 or $6 difference. Either way, the intermediate always reimbursed higher than a level 3. But then if you look, sometimes a visit will earn a level 4 or an intermediate. Well, if I have the choice there, an intermediate, again, is at $86, but a level 4 established patient reimburses $109. I'm very clearly going to pick a level 4. So it's that strategic coding that can make a huge difference at the end of the month. So we'll grade each one of these visits in the examples that will follow as both 99 and 92,000 code. We'll then look at the strategic coding difference based on this graph, and I'd encourage you to make one of these charts for your top payers to make sure that you're choosing the correct and best reimbursing code every time. But we'll then decide which code set we should utilize for that individual patient. So example 1, a simple red eye. So the chief complaint or the reason for visit is a red eye. We do an HPI, it's the left eye, it's painful, it started a couple days ago, and of course artificial tears and Visine didn't help. So if we look at that, you have 4 HPI questions. So that's extended. We do an ROS. We only asked about eyes, and because it was a red eye, I'm going to ask about allergies, so we only have a 2. So if you look at your grading sheet, 4 HPI questions is extended, and 2 ROS puts you at an extended ROS. And here we just did a patient past history, and it was negative, so I only did problem pertinent. When you look at the chart over to the right there, that gives you detailed, an extended HPI, an extended ROS, and a problem pertinent past family social history. That's a detailed history. Now we go down to the exam. You can see here we did 12 elements. So we did acuities, pupils, EOMs. We did a slit lamp, so anexa, iris, cornea, anterior chamber, lens, bulbar conj, palpebral conj, IOPs, and then we of course did the 2 mental elements, orientation and mood and affect. That gives us a total of 12. So we did not do an internal exam, so we're not getting credit for the 2 internal components. So that gives us 12 elements. Greater than 9, that gives us a detailed exam. So this patient had a red eye, and based on this slit lamp, you see on the left eye there is some SPK there. So we have a detailed history and detailed physical exam. Looking at this, even before we know what the medical decision making is, even before we think about that, we're already at a detailed detail. That's going to give us a 99214. That's a level 4 office visit. So on this case, we have the diagnoses. We have punctate keratitis of the left eye. Our management option was start a steroid and have the patient come back in a few days. So we have 1 diagnosis, 2 management options. That gives us a total of 3. So that gives us limited medical decision making, or the management options. Then if we go all the way down to risk, you can see the risk is 1 acute illness or injury. This was low risk. So we have limited and low. So the entire thing here comes down to low complexity. So we are not doing the amount and complexity of data review, because one, that would be minimal. We didn't really review much data here, but you only grade the MDM on 2. So even if this happened to be extensive complexity, you'd still only get low because the 2 of the 3 components are in low. So with that, we have low complexity for medical decision making. So if we grade that for the 99,000 side, if this were a new patient, we'd have a detailed history, a detailed physical exam, and low medical decision making. That's a level 3 new patient. If this were an established patient, again, it's detailed, detailed, low. But on the established patients, you only need to grade it on 2 of the 3. So 2 of the 3 highest categories there puts you at a level 4 established patient, 99214. This is not a rule of thumb, but what we typically will find is if an visit is a established patient level 4, it's probably going to be a new patient level 3. If it's a established patient level 3, it's probably going to be a new patient level 2. It's usually about 1 less. That is not always the case. As you can see, the grading criteria are different for both of these, but very, very rarely, and I think actually it never would happen, that a level would be the same for new or established. It's going to be less on the new patient side. For the 92,000 side, so we graded that as a 99 and it's a level 4 established patient. For the 92s, you can see all those check boxes for an intermediate ophthalmological service. We did all this stuff. It was a new or previous existing problem. We did a history, general medical observation, the external ocular adnexa exam. We did some other diagnostic procedures if they were indicated, and then we have a treatment plan. So that earns an intermediate code. If we tried to grade it for a comprehensive, you can see we did not do gross visual fields and we did not do an internal examination. So it can't be billed as a comprehensive. So our choices here are either an intermediate or a level 4. Well, which one do you think we should choose? It's pretty obvious that if we're going to bill this and try to maximize our reimbursement, we'd submit this to the insurance company as a 99214. Now, on the reverse side, we also talked about this as if it was a new patient. If this were a new patient, it would have also earned a 92002, so an intermediate ophthalmological service. But on the new patient side, it would have earned a 99203. Now look at that. A 99203 reimburses $109. An intermediate reimburses 82. So again, we would have billed the level 3 for the new patient because the reimbursement would have been better. Let's go to example 2. So this is the follow-up for this patient. It's a 3-day follow-up, keratitis exam. We do an HPI. The HPI is going to be very similar to the first time, right? So we have an extended HPI where it's the left eye is still a little dry. We started a few days ago, and they're taking fluorometholone for 4 times a day. So we have 4 for the HPI. This time, because we're just kind of focused on the patient, we're not asking about other stuff. We just have eyes. We didn't do any other review of systems. We didn't ask about allergies or anything like that. So we have an extended HPI, a problem-pertinent review of systems, and we didn't do any past family social history. So if you look at the chart there, we're now going to have an extended problem-focused history, a little more pointed at this visit. The exam is going to be pretty similar to what we did the first time. And that's going to have those 12 elements again. So we still have a physical exam that's detailed. So on this patient, we have extended problem-focused history and a detailed physical exam. Now, that diagnosis is still punctate keratitis. The management option is to discontinue the steroid, continue with some artificial tears a few times a day, and come back when needed. So that's 3 for the diagnosis and management options. So we're at limited. Now, if we go down to the level of risk, it's probably minimal now. It's one self-limiting minor problem or one minor problem. It's no longer being pharmacologically treated. We're not having to come back for a follow-up. It's going to resolve at this point. So now it's considered minor. So if we have a limited complexity of data or low complexity, we have straightforward and then risk of low is going to be straightforward complexity, because on those 2, you'd have to go with the lower of the 2. So straightforward complexity for the MDM. So again, now this is an established patient, but if this happened to be a new one, it would be extended, detailed, and straightforward, so it would have earned a new patient level 2. For an established patient, we have an expanded problem-focused history, detailed physical exam, straightforward MDM. So you notice it's kind of all over the place here, but you kind of get the the two higher ones. So that's going to put you at a 99213. For an intermediate code, you see again, we did all of those elements. We still don't earn a comprehensive. So if this earned an intermediate again, or a level 3 established patient, 99213. So here it's going to be best to use the intermediate code, intermediate ophthalmological service, 92012. The reimbursement is about $12 more. Why wouldn't you bill that? If this were that new patient, you'll notice a level 2 new patient is at $75.73, so about $76, or the 92002 is at $82. So again, you'd still use the intermediate code in that case. So for this patient on their one-day visit, their first day, we would have billed it as a 99,000 code because that reimbursed better. On their follow-up, it's more strategically beneficial to use the intermediate code, the 92,000 code. This is why you need to pay attention here and not always bill all medical visits as 99s and only routines as 92s. Using both code sets makes a lot of sense. Our third example. Here we have a patient presenting with flashes and floaters. The HPI is the right eye. It started 4 hours ago, so they're coming in right away, which is a little rare. Partial field loss, they're noticing something going on there, and they noticed it after they took a nap. So we have 4 HPI elements. So we have the location of the right eye, we have duration for 4 hours, we have associated signs and symptoms, and also we have context. So that gives us that 4. So we have an HPI of extended. Our ROS, we're asking about eyes. Because they're talking about flashes and floaters and partial field loss, I'm going to ask neuro questions because it potentially could be a migraine, right? So now that gives us an extended ROS, and we didn't do any past family social history here, which I know might be kind of rare, but let's say we didn't. So that's none. So for here, you have to have graded it out of 3 of 3. So that's an extended problem-focused exam because you didn't do any past family social history questions. If you would have asked any past ocular health questions, that would have put us into that problem-pertinent past family social history, so that would have been detailed. But for this example, you see it's expanded problem-focused. For the exam, we did visual acuities, pupils, fields, gross visual fields, IOPs, we looked at the back of the eye, and we had dilated them. So now because we dilated them, we do get that internal component, and we did the psychiatric elements, orientation, mood, and affect. So when you add all those up, you'll see that it's 8 elements. So we have an expanded problem-focused physical exam. The diagnosis here was a retinal detachment of the left eye. Our management option was urgent referral to a retina specialist. We didn't really have a whole lot of management options here because this is a little outside of our scope. So we have a detachment and we sent it out the door. So our number of diagnosis and management options is 2. So we have limited. Our level of risk here, I'd say, is moderate. This is an acute complicated injury. We're not going to do much about it, so it's not high risk, but we're referring it out. This was an acute complicated injury. So when we have limited diagnosis and management options and we have moderate complexity, that's still going to give us a low complexity MDM because the management options were so low. So even though this is a retinal detachment, the MDM was low complexity. So when we grade this out for a new patient, it was expanded problem-focused history, expanded problem-focused physical exam, and low MDM. So on new patients, you have to have 3 of 3. So on this, you have to go with the lowest of them. So that's going to give you a 99202. For an established patient, we have expanded problem-focused, and low. So here we got a 99213. All 3 of these happen to be on the level 3. Even if the MDM would have been straightforward, the history and the physical exam would have put you at a level 3 office visit. So I like to use this example because you'll notice that this was a retinal detachment and it only earned a level 3. The previous example was a keratitis and that actually earned a level 4 at one of the visits. So it all depends on your treatments and management options and your clear documentation of the entire case. If we grade these with the 92,000 side, you'll notice in the history, or in the physical exam, we didn't do a slit lamp exam, or at least we didn't document anything. We did we did acuities and pupils and all that stuff, but we didn't do a slit lamp exam, or at least we didn't write it down. We looked in the back of the eye and saw retinal detachment. So this visit doesn't earn an intermediate code because we didn't do an external ocular exam. And it's not a comprehensive visit because, again, we didn't do that external exam. And we didn't even do EOMs. So this is one of those examples where a visit could very easily not earn either of the 92,000 codes, and it has to then be billed as a 99,000. So in this case, our only choice is to bill it on the 99,000 side. Example 4, an established patient comes in for a yearly exam. They have distance blur, both eyes for 6 months. They have glare at night and glasses help. So here we have the blurry vision, we have the laterality, we have duration, we have associated signs and symptoms, and we have modifying factors. So that gives us an extended HPI. We have a complete review of systems. So let's say we did the entire ROS because it's been over a year since we saw them. And we did past family history and social history. That gives us complete. For an established patient, for the past family social history to earn complete, you only need 2 of the 3. So the past history, family history, and the social history. So even if you skip one of those, if you did 2 of them, you get complete for an established patient. On a new patient, you do have to ask all 3 in order to earn complete there. So this is a complete history. For the physical exam, we did pretty much everything, including looking in the back of the eye, pupils, EOMs, all that, including dilation. That gives us a comprehensive physical exam. For the diagnoses, we have presbyopia and nuclear sclerotic cataracts. Our management options are update the prescriptions, evaluate cataracts in a year, and told them to get some glare-free glasses at night. So it gives us 5 diagnoses or management options. Some people may argue that presbyopia, because it's not a medical diagnosis, you can't count it. Even if you did that, the management options are still threefold, and the nuclear sclerotic cataract is 1. So 1 diagnosis and the 3 management options would add up to 4. So either way, it gives us multiple for our management options here. Our level of risk is low. We have 1 stable or chronic illness. So it's 1 stable illness here. That's the cataracts. So with multiple diagnosis and management options and low risk, we're at low complexity. So when you have all of that, this was an established patient, but that's what it would grade out if that same exam would have been new. But this was an established patient. We have a comprehensive history, a comprehensive physical exam, and low medical decision making. According to the 1997 documentation guidelines, this visit would have earned an established patient level 5. Now there are some payers, some Medicare regions that will not pay a level 5 visit unless the medical decision making is also high. But if you base this grading solely on the documentation guidelines and the definitions of those codes, this was a level 5 office visit. If we check off the boxes for the 92,000 side, you can see it earns an intermediate and it also earns a comprehensive. So of course you go up with that higher code. So you did all those exam elements, the history, general medical observation, slit lamp, internal and gross visual fields, EOMs, and a treatment plan. So here, your choices are technically a 99215 or a 92014. So for this patient, it would be more beneficial to bill a level 5 and the documentation supports it. If the payer does not agree that a level 5 is warranted, even though by the definition it is, you would then potentially downgrade that to a 99214. And in that case, you'd want to go with a comprehensive ophthalmological service due to the reimbursement levels. Example 5 is for a scratched eye. You can see here that the HPI consists of the right eye. It's painful, it occurred last night. It's a baby finger to the eye, an artificial tear didn't help, and the patient's photophobic. That gives us an extended HPI, so you see 5 elements there. Then you go on with the review of systems. With the patient, since they said it was a scratchy eye or a scratched eye, we're going to ask about some immune systems because we're potentially looking for any collagen disorders or things that would cause them to not heal very well. So we have a review of systems of 2, so the eye and then the immune system. And then the past family social history, we asked about a past ocular or past medical history, and then also we got the social history that they're a daycare worker. So with an extended HPI, an extended ROS, and a complete past family social history, we're going to be at a complete history. The physical exam, we went down and we did acuities, gross visual fields, pupils, EOMs. We did a corneal exam and bulbar conj. We did 2 slit lamp elements. We did IOPs and then the psychiatrics. That's going to give us 9. So we have a detailed physical exam. When we go into the medical decision making, you can see we have 2 diagnoses. We have a corneal abrasion and we have a subconjunctival hemorrhage. Our management options are the bandage, contact lens. We put them on some antibiotics, and then we said to come back in a few days. So we have 2 diagnoses, 3 management options for a total of 5. That gives us multiple. We then go down to risk and see our risk is low because we have 1 acute illness or injury. So with multiple diagnoses and management options and low risk, we have low complexity for our MDM. When we grade that out, if this were a new patient, you can see we have the comprehensive history, we have a detailed physical exam, and low medical decision making. That's going to give us 2 of those 3 are going to be in the 99203 area. We have to have all 3 in order to grade a new patient. So this is a level 3 new patient. For an established patient, the comprehensive history puts us down at level 5 there, but then we have the detailed physical exam and we have low medical decision making. So we have it spread all the way across. But for an established patient, we only need 2 of the 3 categories to make the threshold. So because the history is comprehensive and the physical exam is detailed, this is a level 4 established patient. When we grade this out on the 92,000 side, you can see it hit all of the required elements for an intermediate ophthalmological service. It does not meet it for a comprehensive because we did not look in the back of the eye. We didn't know internal examination. So for here, our options are either a level 4 established patient or an intermediate. So again, it's going to be crucial to keep track of our strategic coding options so our reimbursements are maximized. You can see here that that's a pretty substantial difference between the 2 code sets. So when a visit earns or equally earns both code sets, why not use the one with the higher reimbursement? So for this patient, because it was we did a bandage contact lens as one of the options, I wanted to throw up how to code that correctly. So for here, you have you'd build a level office visit with the injury of the conjunctiva or the corneal abrasion code, initial encounter. So that's S05.01XA. But we also did a bandage contact lens, 92071. But most payers also want laterality on that code, so you'd put the RT. That's all you do for this code, so you'd actually bill for both of those CPT codes. For example 6, we have a patient with a history of macular degeneration, cataracts. They're here for an evaluation. We have an HPI for the macular degeneration of it's being in both eyes, mild, slight blur. They're taking AREDS for cataracts. It's both eyes, it's moderate, going on for 3 years, and it's got some glare issues there. So we actually have about 8 HPI elements, so we're definitely into the extended range. We do all the review of systems because it's been, we'll say, a year for this patient. So we have a complete ROS. And the patient has cataracts and AMD, so we have a past history, the family history of AMD, and they're a smoker. So then we have the social history. So we have a comprehensive or a complete past family social history and therefore a comprehensive history. Our physical exam consists of all of those elements. You'll notice there it's all 14 of them. So we didn't miss a single one of the elements for this particular patient. That's going to give us a comprehensive physical exam. So we already have a comp history and comp physical exam. For our medical decision making, our two diagnoses for the day are, again, macular degeneration, and they still have cataracts, of course. Our management options are those three things listed there. We said keep taking the AREDS, come back in 6 months for a dilation and a retina OCT, and the cataracts are pretty modest, so we'll just look at those again in a year. So come back for those when necessary. So we have two diagnoses, three management options. That's a level 5, or a total of 5. So that gives us multiple for our diagnoses and management options. Our level of risk here is going to be all the way down here at moderate because we have two stable chronic illnesses. So even though everything is stable, there's nothing really changing. These are two chronic illnesses, and right in the definition for moderate risk, it says two stable chronic illnesses. So even though this is a pretty routine visit without anything real exciting going on, we have multiple diagnosis and management options, moderate risk. That's going to give us moderate complexity for our MDM. When we grade that out, comprehensive, comprehensive, and moderate, so that gives us a level 4 new patient. If this were an established patient, we have comprehensive, comprehensive, moderate. So again, like the last one, this technically earns a level 5 established patient office visit. When we bill this on the 92,000 side, you can see we hit all of the elements. We got everything going on. So we have a comprehensive ophthalmological service earned. When we we compare these two options, again, we have a level 5 or a comprehensive. If you have the option to bill this as a level 5, clearly it's going to reimburse about $20 more. That would make the most financial sense. I hope you learned a lot in this video and are now more comfortable using the grading sheets we provide. Once you get used to the way things are laid out within your records and how things are documented, you'll be able to accurately grade your charts on both the 99 and the 92,000 side within a minute. Once you have those two options, you'll be able to strategically choose which code would have the best reimbursement when submitted to a third-party payer. I hope this made a lot of sense to you. Please send us any questions you have, and thank you for watching.